Welcome to Sensitivity and Specificity for V574, Biostatistics and Epidemiology. Warning, this entire section has a high probability of being on the boards. Sensitivity and specificity definitions. Sensitivity, a measure of how often a test correctly detects a positive result. Examples, how often does measuring blood sugar levels detect diabetes? If only using IOP as a measurement, how often would we correctly diagnose glaucoma? Specificity, how often a negative result from a test correctly determines a person does not have the disease. An example, if we only used IOP, how many people would be correctly told they did not have glaucoma? Great, so why should optometry care? Because it influences every single decision we make for the rest of our lives. How much confidence do you give in your testing with a patient? If the sensitivity and specificity is high, you can have good confidence. If it's low, maybe you have no confidence. Maybe you feel like you need to repeat the tests to make sure you have a correct result before you start diagnostics and treatment. Here's another example of sensitivity and specificity. Let's look at glaucoma and pressures. Glaucoma tonometry has a high sensitivity and specificity to detect ocular hypertension. That's people above 21 millimeters of mercury. But it's actually relatively terrible to detect glaucoma by itself. You need other things like optic nerves, visual fields, etc. We can look at this Lales study over here to show us an example of that. What if we only looked at considered people with glaucoma to have pressures above 21? Well, that means all the people down here, first of all, that do have glaucoma aren't detected. All this group would be misdiagnosed as not having glaucoma, they wouldn't be treated, and they potentially could go blind. Conversely, if we look at all the people above here, we detect a lot more people with glaucoma because the pressures go up as expected. But there's an awful lot of people still over here, from 22 to even 26, 27, 28, that don't have glaucoma. Even at 28 millimeters of mercury, only 40% of the people at 28% go on to have primary open-angle glaucoma. Typically, we think of sensitivity and specificity using a confusion matrix to analyze and calculate our data. An example of a confusion matrix is on the right. We first can look at the true condition. These are patients who actually truly have the disease, and that's usually done through a gold standard or long-term monitoring to make sure they truly have the disease over time. Again, that means patients absolutely had the disease or didn't have the disease. Now, this predicted condition is typically looking at the new test. Say we have a new test for detecting glaucoma, a new test to detect myopia, whatever that might be. And that's looking at to compare what the two measurements received. We know one group truly had them and truly didn't. How often can that new test correctly diagnose people with the condition and without the condition? The reasons why it's called a confusion matrix is there's times where the new test doesn't correctly measure. Sometimes it says it's in one group, sometimes it says it's in the other. True positives let's go through a few more definitions first. True positives, people with the disease correctly diagnosed as having the disease. That's pretty straightforward. True negatives, also pretty straightforward. People without the disease correctly said to not have the disease. That's what the ideal world is. Everybody would be a true negative or a true positive, and we never be confused. The reality, though, is we have things like false positives. Those are people who we said had the disease, but in actuality didn't have the disease at all. That's like going home and telling your mother she has glaucoma when she actually doesn't. It might have some effects on her emotionally. It might put her on medications for the rest of her life that she doesn't need to be on. So there's a real cost to actually misdiagnosing somebody to have glaucoma when they don't. Conversely, there's false negatives, people who actually have the disease, but we incorrectly diagnose as not having the disease. This is like telling your mom she doesn't have glaucoma, but then she goes on to lose her vision because of it. Sensitivity, our definition, if we think about that correctly, is the people with the disease truly having been diagnosed with the disease. So to calculate that out using confusion matrix, we look at only the positive values, the true positive values. In this case, we know we have 102 people that were correctly diagnosed with the disease and 17 people with the disease who are incorrectly diagnosed or are false negative. To get sensitivity, we calculate that by having 102 divided by 102 plus 17. That's all the people with positive conditions. And we get a sensitivity of about 86%. Conversely, you might see the specificity. That's people without disease truly not having the disease. In that case, we only look at the true conditions of the negatives. So we want to calculate the specificity. We take the people who are true negatives, 124, and we divide by all the negative conditions possible. So that's 124 plus 10 to get a 93% specificity. Well, let's look at some real-world examples. Here's a real-world example of a new system that came out in line. It's an AI-based screening technique to detect diabetic retinopathy. It's a screening technique. It's not used in eye care practices. It's not in ophthalmology. It's not in optometry. It's really only used in pharmacies, drugstores, screening centers, just general primary care doctors right now. And it's got a very high sensitivity and specificity for detecting diabetic retinopathy, sensitivity of 97% and a specificity of 95%. So you think that's pretty good. But it always really truly matters on what we're trying to do with that device. In a screening device, we might really just want to make sure that we detect people who have mild to no diabetic retinopathy so we can appropriately send them to the appropriate place. So that's like looking up here in this top upper corner of the same data. This is a wider data set from the same instrument. In that case, we have that same sensitivity and specificity that we just found in that previous study, where it's relatively high. And that's totally fine for a screening device because we never really miss any of the more severe cases. Those are always correctly diagnosed. However, though, if we start to look at the device and how well it detects things like macular edema and severe proliferative neovascularization, which we can see down here in the red, that's a completely different situation. While we still have high sensitivity and specificity, it's now missing people with proliferative diabetic retinopathy. In this case, if you're trying to, it's critically detect everybody with proliferative diabetic retinopathy. So even though this has high sensitivity and high specificity, it's still not good enough yet to be used to diagnose proliferative diabetic retinopathy. These people are going to go blind very quickly in a matter of days to weeks, and we can't allow this little screening device to miss them. And in a doctor's practice, they wouldn't be missed for a whole host of reasons. In short, sensitivity and specificity are desired for most tests. However, even high numbers may not be enough in situations where missing one case is critical. And that depends on how important it is to catch all cases. It also might depend on how important it is not to diagnose people without the disease. Maybe the cost to the person if we misdiagnose them is very high. So we want to make sure we judiciously control our sensitivity and specificity. For the remainder of this class, expect to know how to calculate both. This will probably be on the boards in some format. Thank you very much. Bye.